phacoemulsification in a wide intumescent hypermature cataract is a challenge because of two reasons. One, the reduced visibility of the anterior capsule during CCC because of poor red reflex, and raised intralenticular pressure in intumescent hypermature cataract adds to the difficulty. Several techniques have been described to avoid rexus runoff in intumescent cataracts, such as decompressing the swollen lens, aspirating the liquid cortex after the initial puncture of the anterior capsule, mini rexus or two-stage rexus, and so on. We present our novel technique to create CCC in intumescent hypermature cataract using bimanual irrigation and aspiration. Our surgical technique is as follows. 2 adequate side ports are created. (0.1% trypan blue dye is injected into the anterior chamber to stain the anterior capsule. After a few seconds, the dye is washed off the anterior chamber. The anterior chamber is now filled with viscoelastics. The use of ophthalmic visco devices is recommended to maintain the positive pressure in the anterior chamber. A 26 gauge bent needle is introduced through the side port to puncture the anterior capsule. We can see the liquid cortex oozing out of the capsular bag, obscuring the visualization. Now we introduce irrigation and aspiration cannulae through the 2 side ports. The oozing liquid cortex is aspirated using the aspiration cannula. With the same cannula, the anterior capsule is lifted till it folds back on itself. Now the leading edge of the anterior capsule is held and continuous curvilinear capsular rexus is fashioned. One more thing that makes a regular continuous curvilinear capsular rexus tricky in such cases is, after the aspiration of liquid cortex in the hypermature cataract, the bag becomes spatulous. The cataractous lens is seen floating freely in the bag. Such lens offer minimal or no support to the anterior capsule during regular CCC. In our technique, CCC is independent of that factor and can be performed successfully. We have one more video where we demonstrate our technique as a 2-stage procedure. After the initial anterior capsule puncture, the rexus is started with bimanual irrigation and aspiration. As described earlier, the surgeon first lifts the flap and then grasps and re-grasps the leading edge of the capsule flap till the CCC is complete. Now the second stage of the rexus is started with a nick on the rexus margin. The surgeon again goes in with bimanual irrigation and aspiration, holds the torn edge of the rexus margin and enlarges the rexus. The phacoemulsification settings while performing CCC with bimanual irrigation aspiration is same as the settings used for visco removal after phacoemulsification. Most importantly, the capsular excess is controlled by the surgeon using the phaco foot pedal. Results: anterior capsule staining with the blue dye enhances the visibility of anterior capsule. A novel technique helped in creating a controlled and successful CCC in intumescent hypermature cataracts. To conclude, we recommend the use of this novel technique in intumescent hypermature cataracts. Thank you.